Welcome to another episode of 7 Minutes Medicine. Today we're going to talk about pulmonary embolism diagnosis. So first, some terminology. The definition of pulmonary embolism is obstruction of the pulmonary artery or branches. So the timing, it can be acute within hours, subacute within days to weeks, and chronic over months to years. The anatomical classification: lobar, saddle, segmental, or subsegmental. First, we're going to talk about the risk factors. It might be genetic risk factors like factor V Leiden, prothrombin, protein C and S resistance, atropine deficiency, factor 12 deficiency, and dysfibrinogemia. Or it can be acquired, and the acquired can be provoking, like recent surgery, trauma, immobilization, active cancer, hormonal therapy. It can be non-provoking, like obesity and smoking. So the patient may come with shortness of breath, chest pain, which is pleuritic in nature, cough, wheezing, hemoptysis, and arrhythmia, and presyncope. And hemoptysis is not quite often in PE. Dyspnea and shortness of breath, chest pain is more quite often. And if it's massive PE, then you may have presyncope. For the signs on your physical exam, you may see tachypnea, cough swelling, which is indicate clot in the lower extremities, tachycardia, rales, decreased breath sounds, GVP if it's a massive PE, and fever. And fever is important because it's overlooked. Fever can happen once the patient has a PE. So the next step is to define the pretest probability to know what kind of diagnostic test we should order next, or the Wills score. So if the patient has lower extremity exam consistent with DVT, we give it 3 points. If there is no alternative diagnosis, we give it 3 points. Tachycardia more than 100, 1.5 points. Immobilization more than 3 days or surgery in the last 4 weeks, 1.5 points. History of thrombosis, 1.5. Hemoptysis, 1 point. Malignancy, 1 point. And if the calculations give you a score of less than 2, this is low risk. If it's 2 to 6, this is moderate risk. And if it's more than 6, this is high risk. So the diagnostic approach. If the low probability, like low risk, then we do D-dimer. If it's more than 500, we can do CT angio or VQ scan. And here's the thing, some literature supported the idea of using the age-adjusted D-dimer, but some other experts recommended against. So there's some controversial area. If intermediate probability, also you do the same thing exactly as you did with the lower probability. You do D-dimer first. If it's more than 500, then you do CT angio or VQ scan if you cannot do the CT angio because of the kidneys. If it's high probability, then you go straight to the CT angiography. What kind of also lab work you have to order? CBC, and it can show leukocytosis, and BMP, and this is important because it's going to give you the creatinine level. So before you do the CT angio, you want to make sure that the patient does not have chronic kidney disease. And ABG is very important and going to show hypoxemia, wide AA gradient, respiratory alkalosis with low CO2 because of the hyperventilation. It's washing out CO2. BNP for risk stratification, and if the BNP is elevated, this is worse prognosis. Troponin, also the same thing, it is a poor prognosis. And why BNP is elevated? Because if you have a big PE, This will cause dilation of the right ventricle, and this will result in elevated BNP. The troponin also, if you have uh, too much stretch and some death in the muscles of the ventricle, it can leak and cause elevated troponin, and this is a sign of poor prognosis. And there is also some non-specific elevation ESR, LDH, and AS. So after that, to decide what kind of management you need, you have to classify the severity of the PE. First, a massive PE is unstable, and we mean by unstable any of the three things: systolic blood pressure less than 90, a drop in the systolic blood pressure more than 40 for more than 15 minutes, or hypotension requiring the pressure not explained by other causes like septic shock, myocardial infarction, and arrhythmia. So this is a massive PE, and we have always to classify our patient. The second one is submassive PE, which is the intermediate risk PE. You have evidence of RV strain, and you can know this from the echocardiography. Uh, and some literature supported the idea that the CT scan will give you some answers about the RV strain, but a better tool is to use the echocardiography to look for the signs like McConnell sign. But there is no evidence of hypotension. You have RV strain, but there is no evidence of hypotension. This is submassive or intermediate risk. Low risk, it is stabilized in response to fluid. There is no RV strain. There is no hypotension or shock. After that, you can go to the management. Thank you for listening. We're going to have another lecture about the management of PE. If you like our content, please subscribe to our channel. Bye.